So no disclosures pertinent to this, except for I know we have a lot to go through within about 20 minutes. So I'll try to get through all that efficiently for you guys. My charge today is talk about intramedullary screw fixation. And when you're talking about this within the hand, of course, we know we can do it in the carpus. We've been doing that for a long time, but particularly we're talking about doing this in metacarpal and phalanx fractures, right? And so in the metacarpal, we're looking mostly at doing it in the neck, in the shaft, in those regions. And in the phalanx fractures, we're looking at the middle and proximal phalanx in the neck shaft and base, actually. So a little bit of background here. We know fractures of the hand are most common fractures in the upper extremities. We see a lot of them, most commonly in males, peak age 10 to 40 years old, doing some silly stuff sometimes. I love this quote, and it pertains to everything that was talked about this morning, as well as these fractures too, that hand fractures can be complicated by deformity from no treatment, right? Stiffness from over treatment, and both deformity and stiffness from poor treatment. So, and the therapists know this very well here, and this is something we always keep in mind. And all these talks go together. And part of the advent of this technique was to try to get motion quicker, decrease stiffness, have a better option for patients that it's appropriate for. We know the majority of the hand fractures we see are closed, simple and stable, and we want minimal splinting, early mobilization that was touched upon. Also, that was touched upon, on our exam, a lot of things we're looking at, of course, one of the most common things, the most important things, that we need to focus on here is their rotation, right? And any kind of rotation is not really a good thing for patients. So that's really an important thing. Extensor lag is another issue, and other deformities. Again, we have these non-operative treatments, and we try to employ them when we can. But when we talk about surgery, there are certain indications that particularly pertain to these fractures too. But in general, failure to achieve our closed reduction, right? If we can't keep that reduction either. So if we can't get it, we can't keep it. We have multiple unstable fractures. Open fractures can be an indication. Other indications too that, of course, are the patient, right? What are their demands? So what is their occupation or sport? What are they hoping to gain and when? So those are important aspects. So obviously we know about K-wires. Dr. Hoyer did a really great talk on that. And I think this is, like he had mentioned too, this is the oldest, cheapest, simplest thing we can do. But you got to do it in a good way, right? You have to have good technique in that to minimize those complications, and you show that really well. External fixation, we're not doing a lot of, but still an option for bone loss and other types of certain cases. Plates and screws that was mentioned as well. And then what we're talking about today is screws alone, right? So we have multiple lag screws, but what we're focusing on is intramedullary screws. So, here's an example of a patient who had multiple injuries, and you can see had multiple screws placed and different patterns, right? So you can do this antegrade, you can do it retrograde, you can do one screw, you can do two screws, you can do fully threaded, partially threaded, compression, non-compression, right? So this has evolved quite a bit over the last decade and some change. And so this is one thing we're going to talk about, and something we don't fully understand the best just yet either, that we need to keep studying. So we'll start with metacarpal fractures. And we know that the fracture pattern is also important. So we have transverse fractures, we'll see oblique, spiral, comminuted, and again, those locations that we're looking at there. This kind of technique is really not so good for head fractures or base fractures in the metacarpal. It's more in that middle zone neck shaft. This is also touched upon, but again, we know metacarpal neck fractures are the most common things we see. Most of the time, we're treating them non-operatively because they usually do well. They can accept a lot, especially in the fourth and fifth, more so than our radial metacarpals. Non-union virtually never occurs. Malunion can be a problem, though. And so this is one of those techniques that if you have a patient, you maybe have more of a discussion now. Hey, maybe we should treat this, whereas before we wouldn't have, to get you moving quicker, to decrease chance of malunion and other issues, because there can be problems. They can lose their knuckle. They may not like the look of that or the feel of that. If they have an occupation where they're gripping things a good amount, they may feel that metacarpal head, and that can cause a problem for them. Of course, rotatory malalignment and the pseudoclawing can also be issues. So I won't go over this too much, but we know that there's certain parameters we look at and certain things we can accept. Luckily, we don't usually have a lot of shortening in transverse type fractures in the metacarpals because of the intermetacarpal ligaments preventing a lot of that. But that can be an issue once we get greater than 4 millimeters. 7-degree extensor lag for every 2 millimeters of metacarpal shortening, right? So These are important things that can cause issues for patients. Again, we know about K-wires, a lot of different ways we can place K-wires in. They still have good indications, and we need to consider that, be cost conscious at times as well, of course. And this is just some examples of different things you can see here, how we can use K-wires. An example of a case recently, we did that. So what else can we do? Well, yes, we can use lag screws alone. This has been shown, and I also agree that especially for your length and stable type fractures, right, your long spiral oblique type fractures, you're going to be considering something like that versus intramedullary fixation. Plate and screw fixation, we have various options. We know different companies have different patterns, or there's going to be different designs, different ways you can place this in, and we need to kind of understand that and when that's the most appropriate. So that brings us to what we're talking about now, this intramedullary screw fixation. And we say that, we used to say headless compressions at first when we first started doing this, but now we have more designs where they're not all compression screws, right? What are some of the benefits of this? We know it's simple. There's no hardware prominence, usually, unless there's an issue. Need for removal. It's stable fixation, right? And it's early range of motion. And those are the two key things really is getting them moving early, having stable fixations, and decreasing that stiffness that we all fear and that we all worry about having to deal with. What are our options? Currently, there are a lot of different implant options. We had started with a small amount of different screws, and now it's expanded over the last decade, and I imagine it will continue to some degree. And along with that, different types of screws, different techniques, right? So headless cannulated screws. So these are all cannulated, right? So you have a guide wire, you place that, you get your reduction, place that, and then you have that screw follow that path, right? But remember, two things that we always keep in mind here now: is it compression or not, right? So it depends on the pattern of the fracture. One of the nice things we have now too are multiple sizes. So we get anywhere from 1 millimeter up to 3.5 millimeters in the hand usually, and that's depending on where we're putting that in. So you want to understand which bone you're looking at, right? And what size screw is appropriate for that patient. The ones here in the middle, not sure which one the laser pointer. These are non-compression screws, so they kind of cut into the bone, and that's in a case where you don't want to overcompress, such as comminution, something like that. And you can see just the variable. These are just a small amount of different types of screws that are out there. So here's a case. So we love this technique. We're doing more of it, right? But we don't want to use it like a hammer and treat all of them the same way, right? We can't. So this is a case that I thought, it would be good to show that in the fifth, I thought this would be a good one for a screw, intramedullary screw, but that third one, third metacarpal, is more of a long spiral oblique, more length and stable, more concerned about that. And so that's what I did for this patient. And so having a combination at times, of course, is okay. If you're using a company that has everything in one set, great. Otherwise, you might need to have different sets if you're thinking about using different techniques for different fracture patterns. So long oblique, we got to be careful with, and comminuted. So there are some people who believe that you shouldn't use this for comminution. Some people believe it's okay, but it depends on, I think, on the amount of comminution you have, right? And you have to be careful not to shorten. So if you're using a screw that doesn't compress, more appropriate in that setting. So a little bit of brief history. Again, we started with using headless compression screws in the metacarpal, and we have fully threaded, partially threaded options. And again, these were compression, great for transverse, maybe short oblique fractures, kind of limiting us to most of those fractures in the beginning. And this was really mostly done at fourth and fifth metacarpals and expanded from there. And then from then on, we've now developed these non-compression screws, and we've progressed now to the Phalanx, right? And that's exciting because, as mentioned earlier by Dr. Garcia and others, that the phalanges are challenging for all of us, especially with the stiffness when we have to fix these. So if we have something that's intramedullary, smaller incision, simpler to get to, that's a much better option for us. And there's different insertion techniques now too, to where we put that. Do we put it through the base and the condyle? Do we do it retro, integrate, et cetera? We have a lot more studies now as well, and again, more implants. So this is definitely a growing field. This first case report was by Bolton et al. Back in 2010. So not that long ago, really. looking at their technique and their case and reported on that. And as Dr. Nidek had mentioned, we expanded upon this a little bit with a case series looking at patients in the 5th metacarpal. And they had done well. A lot of these patients were military patients who were able to get back to their activity level pretty quickly without having residual stiffness and issues. So that's looking at acute fractures, right? What about malunions? This was an interesting patient. He's a 24-year-old who had presented. He went over everything with him, of course, and decided to hit non-op treatment. I thought it was appropriate in his case. And then a couple months later or so, he's like, I changed my mind now. This is bothering me. The metacarpal head, when I use it for work, it bothers me in the palm. So we went in and did a small osteotomy, used this nail that this company calls it, and had a good outcome here. I like this one in particular because we had a good amount of threads there. I was worried about that bone. We didn't have a lot of bone distally. I was able to capture that, had a nice stout structure to kind of keep that reduced, and he did really well with that. So what's our technique? We can do this open versus percutaneous. We need to obtain a reduction, of course, place that guide wire, making sure multiple times in the fluoroscopy that you're maintaining the reduction, you have the appropriate position, because that's the key, and then putting the screw after that's the simple part. So we're going to open articular surface with a drill. Some of these implants involve drilling over the screw, over the K-wire. Sometimes you can just place the screw in, depending on your bone quality as well. So we'll go through some steps here. This is some pictures we have looking at the metacarpal. So looking at the 5th metacarpal, approaching that in a retrograde fashion. We're making an incision over the MP joint, and we're going to take care to identify the extensor tendon and the sagittal band, and making sure whichever way we're going through, whether it's through the tendon or through the side, through the sagittal band, that we make a small incision as possible, that we take care to repair that later. And visualizing that metacarpal head, we're flexing that down using the Joss maneuver, whatever we need to kind of keep our reduction depending on what fracture we have. And we can see where we need to put that pin, right? And that K-wire, and that guide wire is in the dorsal third of the metacarpal head. And you kind of follow that down on the fluoroscopy. What's also nice is you can put the screw right up under fluoro, right? Or some companies have an actual template guide to see what size you're going to be using, what length, maybe what diameter. And there's some examples or some pictures showing that going in, and then testing, making sure your rotational alignment, your length, alignment, rotation are all appropriate. So that's kind of how we started with a lot of it. Now it's progressed again to the proximal and middle phalanx fractures. Most of these are going to be shaft extra-articular base, and you can consider a neck/neck to distal shaft junction depending on the fracture pattern. Some people may advocate for intra-articular. I think it depends. Like if say you have intra-articular condylar base type fracture, maybe depending on how you put that in, and so that's still reasonable, but that's not as common. We know that we have a lot of angular deforming forces in the phalanges from the different tendons attaching in different areas, as was mentioned earlier as well, that we need to keep in mind. We had presented and published on this one this past year, looking at the current state of all this. And so this is a good review, I think, of what's out there, what's been happening with this type of technique in the phalanges. And so that's that paper there, kind of a good overall technique of that at the current time. So now I'll try to go through some cases. And some of these I think are pretty interesting. So like this is a patient we saw fairly recently, had a crush injury, closed, but very swollen. And we got him fixed very quickly with these small retrograde screws that gave us compression, gave us very good stability early on, and we got him moving very quickly. I think we just maybe very minimally immobilized him, maybe just a few days, and he's doing really well so far. Now, the key with these, and we'll talk about one thing that's always a concern, is when you're placing these in, right? What happens to the articular surface? What happens to the soft tissues? Are you having to go through tendon, right? Well, here you're going through the distal aspect of the extensor tendon, but they're very small. You want to try to pick small screws to do that, and making sure you're cognizant of that and repairing a tendon if you need to. But he had no extensor issues. This is a Another case, courtesy of Dr. Neidig, he did recently under Rollant, and this is nice when we can do these cases under Rollant as well. And so this is a shaft base fracture that that he did in a antegrade fashion. I think one key thing when we're talking about those, you're placing antegrade, is how much motion once they're relaxed or asleep or however you're doing it at that MP joint. Some people are very flexible. You can push that up and get to that base. Some it's really, really difficult, you know, like mine, they can't move it at all. So that's also important on your patient, where you put that that screw and how you put it in. So this is one similar to the first one, where, you know, this is a middle phalanx fracture with some comminution, right? So here's a comminuted fracture, not highly comminuted, but there is some, and we treated this in a similar fashion, and got good stability, did not compress, and this is a good technique here, I think, as long as, again, you do it the right way and be cognizant of compression, make sure you have good rotation here as well. So this is a patient I had done a couple of years ago early on here in practice at FOI, and he had multiple injuries, crushing injuries, and we placed K-wires. We were happy with that at first, but of course, normal complications of stiffness, therapy issues with him, and he then went on to develop a non-union. This is kind of early before we took his pins out. This wasn't having good healing. Took his pins out, tried to see if we get some healing, give it some more time. Bone stimulator, nothing. So worked him up for infection, of course, our non-union stuff, negative, and then took him back, and we ended up doing this, and eventually had really good healing, you know, and it's one of those cases where I was like, well, maybe I should have done it in the get-go, you know, could have got him moving quicker, had less stiffness, and so I was happy with that in the outcome in the long run. But also can be considered for these non-unions, because K-wires, as we have talked about, can complicate a lot of things, and they don't give you that compression, that stability sometimes you need. This is another phalanx-based fracture. So when we're looking at these, it's the extra articular, remember, most of the time, also placed in that antegrade fashion, getting a good early range of motion. This is a patient, I think similar to the ropes course, when he was doing tug of war at USF and got his hand caught up, had multiple fractures. And this was interesting. One of the first ones I have did this technique where we're using this a pin guide that kind of has two different sizes on the K-wire that you can drive through. You're not really drilling it all. And thought he was appropriate for one screw. Some people may advocate for two screws here. And again, that's one thing we're going to be looking at, trying to figure that out. But he ended up doing really well with just the one. And you can see we're placing that either on the radial or ulnar side, and not going right through the articular surface or close to it. And you just want to make sure that you have that pattern appropriate for that. And it's usually a base fracture. Sometimes in the shaft, you can get by with this as well. Excuse me. This patient, but they don't all do so well, right? So this patient, I wanted to show, I had done some of these other ones, and this one I was going to do a similar technique, pretty confident in that. She was a dog bite injury, took her back, and we did, I did this one screw like this, right? So I wasn't super happy with the lateral, a little bit extension there, but that's acceptable. And I didn't want to take this down and redo it. I thought it was going to be okay. And she was very stable in the OR, but she comes back and she had shifted, right? So she moved, and she did end up healing and did okay. But in retrospect, probably doing two screws, a different pattern, would have been better for her in that regard, right? So you definitely got to consider all those things. Think about that pattern is a big key here. I think more so definitely in the proximal phalanx fractures. And so that's one of our next steps. So, we got to figure out, is it X pattern? Is it a V pattern, a Y pattern? Is it one versus two screws? And how do you, what angle do you put it in? Is it down the pike? Does it need to be from a certain angle? So that's one thing we're going to start looking at, a biomechanical analysis here. Actually, at 5 labs looking at some of that. And I'm sure there's going to be a lot more research coming out, and hopefully it'll give us more answers, and we can maybe be particular about which fracture, which pattern we use. So post-operatively, we know this is oftentimes much preferred because we can get them moving again quickly, usually 1 or 2 weeks or less than that, usually actually, versus pins, plates and screws having other issues. So, and we've touched upon that. So, but there are limitations, right? There are still limitations on screw lengths and maybe some diameters. We're getting more options with that. Again, watch out for the length and stable patterns, long oblique, comminuted fractures, articular fractures, questionable depending on what that is, or most of the time we're not. Hardware prominence and failure can happen if the screw backs out. That's rare, but it can happen. Don't think that it can't. And then one thing that always comes up is cartilage defect, right? We're putting this through an articular surface. Is that causing a problem? This was looked at back in 13, pretty early on, doing with the metacarpals by Tenberg et al. And they had found that when they place it, and they did it under 3D analysis, it's a very small, or 3D CT analysis of a very small percentage of the articular surface is actually evolved, right? And the area of violation was least during that clinically significant sagittal plane arc range of motion. So not much there, right? Here's another study, more recent, looking at when you're placing it through the proximal phalanx head, so distally there, with a smaller aspect of bone, so it's gonna be a higher percentage, about 20%, what they saw here, right? So it's a little bit higher amount there if you're putting it retrograde through the PIP joint. And then if you're doing antegrade, so the base of the proximal phalanx is a small amount as well. It vary between about 4.6 to 8.5%. There is a technique, kind of like placing the K-wires through the metacarpal head, right, into the proximal phalanx. You can do the same thing with the screw. So if you're having difficulty, as we talked about, flexing it down, getting that screw through the base of the articular surface, you could put it through the metacarpal head. You have a more direct path. However, then you're violating two articular surfaces, right? You're going through the metacarpal head and a proximal phalanx. In this study, they said it wasn't much of a difference, but that's something that probably try to avoid that in most cases if we can, I think. So right now we think that if that fills in with fibrocartilage and that doesn't cause an issue, we use this technique, right, for microfracture in the knees. We use it in scaphoids and other articular bones. And so far, there hasn't been any studies that have shown any major long-term arthritis or issues like that. So this review, safe and strong, early range of motion, no removal of hardware. Remember when to consider this, not all the time. Understand the different implants that are coming out and learn more about the ones that are changing and the techniques of how we do this in the different bones. Thanks.